great to see you all here and so many Pectus enthusiasts as well. And it really has been a wonderful journey. I'm also delighted that Shyam has not come because I get to talk for even longer, which is fantastic. So we're going to talk for about half an hour all about where we have got to and the Restore trial, which really is a fantastic testament to UK SCTS surgeons who've worked together to make this happen. This is the reason why we're all here. So this is Autumn Bradley. She came to me when she was 11 years old and she had very severe pectus. She had a Haller index of 9. She used to be a county runner and then she started getting more short of breath. Her brother actually was 2 years older and had pectus as well. We thought, you're a bit young, let's do your brother, wait a couple of years and then we'll do you. So we did her brother. He was fantastically better, healed really well. She came to see me and that was February 2019 where I said to her, I'm afraid the NHS has taken it off commissioning. You can't have your surgery, which was devastating for her. We then spend the next few years going to Parliament, going to Westminster Hall. Simon Clarke MP got it reopened. Very thankfully, she found a benefactor in the Isle of Man, a 92-year-old guy who said, I'll pay for your surgery. And this is now her on her graduation day from school, looking well and holding down a new job, really having a life-changing difference from PEC to surgery, which is why it is not cosmetic. You know, it does have psychological impairment, but, you know, it is physical. It crushes your heart. And you can see by the CT there that, you know, taking the pressure off a crushed heart is why we think this is such an important operation. So, we're going to do a big investigators meeting all about this, but you're very welcome to come on Tuesday. But actually, because I've got a little bit more time, I'm going to tell you everything, so which is really great. So the Restore trial really is a wonderful testament. I'm hugely thankful to Enoch Okoa, who's a professor of cardiac surgery, who's just set up an amazing academic unit in Middlesbrough, who made it all happen. He basically achieved the NIHR £2 million funding that we achieved for this, which is really fantastic. And together with colleagues there, we are now opening this up as a wonderful trial in Britain, which will lead the world really in pectus. This is going to be the world's biggest pectus trial, the world's first randomized control trial, the world's biggest CPET study in pectus. There'll be 900 CPETs. There'll be 300 patients operated on. So, I mean, it's an order of magnitude bigger than anything that's ever gone before, and which is great. And on the right-hand side is that evil report, this nasty, snarling person on the front of this report. I still can't look at that picture. He's an ambulanceman. What the hell are they doing, putting an ambulanceman on a pectus guideline? But that's why we are here, because in 2019, they did a shortcut literature review, one of the worst literature reviews I've ever read in my life. I've done 19 guidelines, and I would never put my name to that guideline. It was shortcut, it was done poorly, and the non-expert panel of cancer surgeons reviewed the 6 papers, of which cardiovascular impairment was excluded in the search strategy. They never looked at a single cardiovascular impairment paper, and they said, we don't think this is worth being on the NHS. Complete catastrophe, utter mistake, and that is where we started in 2019. But the issue that they missed was cardiovascular impairment. We got them to re-review the literature, and then James Palmer, who's in charge of NHS commissioning, still would not recommission pectus. The reason he would not is we showed him 9 studies with 498 patients, all showing cardiovascular impairment on CPET when they have their operation. Like, it's all out there. So the study is going to be positive because we know it works. But NHS England would not restore it onto the NHS because they said they didn't believe that getting better on a bicycle relates to your experience in life. You know, it's like, I want the patients to tell us that they've got better, and all you've got is this strange test called a CPET, which is exercising to exertion on a bicycle. And that doesn't relate to a patient's life of being short of breath. So that's where they set us the challenge. They said, okay, we're not going to bring it back on the NHS, but we will say to the NHR, we would like a study, because it will be commissioning changing. If you get a positive study for us, we will change our commissioning. They have told us that, and that's why we've got the funding. That's why they gave us £1.9 million. So we have to prove that the patient's exercise experience gets better. That's our primary outcome measure. So it's not a CPET, because we don't fully understand CPET. It's a how much better do you get? And physically, they have given us not a penny to talk about psychology. You can't talk about whether they are massive psychologically depressed, if they're introverted, if they have depression scores, if they hate themselves, if they've self-harmed, if they're clinically depressed. They're not interested in that. We're going to prove that you get better. We're going to have 5 psychological questionnaires, but the study is powered only for a physical function score. But that's good, because we're going to prove everything else as well. There'll be an economic analysis as well, which is really good too. So there's lots of things that keep me up at night about the Restore trial. Having been super proud of it, there's then lots of things that scare me massively. The one thing that doesn't scare me is getting patients. There's absolutely gazillions of them. I've got 100 on my phone right now waiting for the trial. I'm sure many of you see patients in your hospitals where you go, God, I wish this person could have surgery on the NHS, but they can't. And they're the perfect person to get into this trial. So I do ask you all, even today, go back to your hospitals and make sure if you see someone with a severe pectus who's short of breath, they must have physical symptoms, they are eligible right now to join the study when it opens in July. But the thing that keeps me up at night is this. This is our primary outcome measure. It's just 10 questions. That's it. The patients before the operation must tick that they're not limited at all. If I've got a patient that ticks not limited at all for all of the questions here, they're going to be top marks already. I can't make them better than top marks. So that will be a negative patient in our study. So we just can't accept patients that will say, yes, I'm not limited at all for vigorous activities such as running and lifting heavy objects. They've got to have some limitation. And some of these questions are not designed for pectus patients. Some of them are kind of, well, you're never going to get a tick on that, are you? I mean, who's going to be short of breath bathing or dressing themselves as an 18-year-old? I just did a lovely 17-year-old girl whose sternum was 7 millimeters from her spine. She collapsed on a daily basis. She hadn't been at school for a year. She had no home teaching. She's missed out a whole year of lower sixth of her A-levels. I was delighted to do it on the NHS through our NHS MDT. 5 weeks later, no, it's about 3 weeks later, she already says she can jog up the stairs and isn't fainting. So she's made a massive difference. She could bath and dress herself. So, she's going to tick full marks on that. That's the worst case I've seen in 3 years. So really, we're down to about, 7 or 6 questions for a £2 million study, and that's pretty scary. But this is the reassuring slide. The wonderful, amazing Dr. J, Dawn Jarefsky in America. She's our leader and hero, and she has done a huge amount for pectus. And one thing she's done, she's kept some really great records, and she's got some really good assessment. One of the questionnaires we'll be using is called PCAPES. It's the Phoenix Comprehensive Assessment. But if you look at the physical function scores that she gets out of this, and these are 430 patients, bigger than our whole trial, average age 30, range up to 78 years old from 11. And she does get a lot of limitation in the kind of questions that we're going to be asking. So this has been very reassuring for me. I think we are going to have quite limited people. We meet them every day. We've done surveys of about 100 patients as well, and thankfully they do score quite much lower than you expect. When you meet these people, sometimes they talk about the fact that, they feel really psychologically impaired and they hate the look of their chest. But then when you delve down, there are a lot of things they can't do. So actually, I think this means that we will definitely be successful with this trial. And so I'm not too worried about the primary outcome measure, maybe a little. So what are our secondary objectives? So CPET's not our primary objective, just because it's very difficult to interpret. You get some people that are very impaired, but you get some people that are not. I've met quite a lot of people that get 100% expected VO2 max after the operation. They feel better, and they run fast, and they go further. But they scored full marks on it, and our CPET physicians say, well, no, they're not cardiovascularly limited. Echo doesn't work. You know, doing an echo at rest, lied flat with your heart flopped to your left chest, is not a great way to see if your heart is squashed from a pectus, because your pectus squashes your heart when you're jogging vertically, when your heart's trying to distend more and get more blood in so that your stroke volume goes up. So echo doesn't work. CT thorax only measures a static index. Cardiac MRI is again static. It's just a posh echo in my view. And so we don't really have great tests. But this is what we are going to have in our study. We will have about 900 CPETs. We're going to be doing it pre-op. We're going to do it 1 year post-op and 3 years post-op, 6 months after your bar comes out. We're going to have 5 different health-related quality of life questionnaires. So we are really going to nail the psychological impairment. We're going to absolutely smash that out of the park, which is great. And we'll do everything that you expect, which is costs, and complications and effectiveness, which is great. We've actually got a little bit of safeguarding that if someone is clicking depression scores too highly, we will be trying to flag that up and get them some psychological support in a small number, which I think is really important. But this, I think we've got a good set of outcomes that we're going to get. I just want to be 100% clear that everybody in this room, when they leave, understands that every patient will get surgery. I've had a few emails of, I've got a patient for Restore, and I'm sending them to you. I have explained to the patient that they've only got a 50% chance of getting the operation. Wrong. NHS England wanted us to do that study and we refused. There is no way I would stand in front of a child or a 17-year-old that's exercise impaired and say, join this study, you've got a 50% chance of having the operation, but if you go into the conservative arm, you must sign a piece of paper promising not to have the operation for the next 3 years. That's just torture for a child or a young adult. So we had a big fight with them, and in the end we said, right, we will go for surgery within 12 weeks or surgery 1 year later. Now, I'm a bit stressed about the 1 year later thing, because when we put it at 1 year, we have to do our primary outcome measure in the randomized phase before we operate on all the conservative group. So we've moved forward our primary outcome measure to 1 year. I'd much rather us at 3 years, because all the studies have been done much longer in the future showing cardiovascular benefit. So really, Dawn told us, do it at 3 years. That's when you'll get your maximum benefit. But if I did that, we'd have to randomize to surgery now or in 3 years' time, which for a 17-year-old, would you like your operation when you're 21? It's like, oh my God, that's so far in the future. No way. And we actually did surveys of this, and people would accept 1 year and not 3 years and not having surgery. But we are taking a bit of a punt. And again, the second thing that keeps me up at night is the fact that we're going very early for an outcome measure. And I really hope it's good. The other reason we're going quick is so that we can get it on the NHS quicker. Because if we do the surgery, we can have the 100 in each arm. We've got the primary outcome measure knocked off after about 3 years. We can publish, we can go to NHS England, and then you can all restart. So hopefully we could restart before the full conclusion of the trial at around 3 to 4 years, depending on how slow NHS England are. So that, I think, is a sensible design, and I hope you agree that we have done an okay job with doing that. So what is the population? When you go out to look for patients, we've written above 12 years old, but realistically, I don't think we're going to have many 12 and 13-year-olds. We'll probably have some 15 and 16-year-olds, but mainly it'll be sort of 15 to 21-year-olds, and there'll be some people earlier than that. Very importantly, you've got to have severe pectus, but severe pectus is more than 3.25 on expiration, and I'll show you some pictures of why that's important. And you must have significant shortness of breath that knocks off some of the scores on my physical function score list, because I don't want people almost scoring full marks. The other criteria are kind of a bit silly because they're actually the ones that are the criteria for NHS England to give you surgery straight away. So actually, if you're going to have those other three, we probably would rather you came to the MDT and got surgery that way. But significant shortness of breath or impaired exercisability is what we want. We're going to do a few things a bit different. So we must have a post-op CT scan. So if you're a surgeon that's done a bit of NUS, you won't have done post-op CT scans, but I've shocked and horrified myself by doing some post-op scans, and the literature would actually say you don't put them back to mild every single time. Not at all. I still remember somebody I got from 9 to 4 and had to redo her operation. So you know, we give ourselves big surprises. We've got to turn their chest into a circle, not a flat box. That's actually got a bow at the front. So we're doing a different operation. We're not doing an operation to look better anymore. We're doing an operation to unsquash a heart. So you've got to think about what's underneath the sternum, not what's above the sternum. That's quite different to what we're all used to doing. And we're going to use the post-op CT to benchmark quality, really, because we want everybody to be improving the Haller index by the same amount. Now, this is really important, and a takeaway message is how important an end expiratory CT scan is. And this was literally 4 weeks ago, this scan. So I started reading the literature about sort of how we're going to do all the scans, and somebody started saying, you've got to do end expiration. I'm like, oh, why do we need to do that? So I did it in a patient. And I was horrified. It was end inspiration was 3.8, and expiration is 5.2. And the literature says your Haller gets 30% more severe on expiration than inspiration. And then I thought about it, and then I thought, Joel, you're a complete dick, aren't you? If you breathe out, your sternum goes in. How obvious. I mean, that's what breathing is, isn't it? So, you know, and suddenly I'm like, why didn't I realize this for bloody 10 years? You know, what an idiot. So it just stands to reason that we've got to do it in end expiration because you want to know the most severe. And actually, I think we might be able to create a bit of a new score where if your change in end inspiration and end expiration is massive, and so your chest is collapsing in, that might actually be an indicator of severity. So we're going to recommend an ultra-low dose CT in end inspiration and expiration so that we can measure the difference. I've talked to a few radiology departments. Again, I'm slightly concerned that some radiologists might go mad about this, but actually I've been very reassured that when I've gone to radiology departments, they're like, yeah, we do this all the time. We do it for pulmonary fibrosis. You know, you put people on their fronts, breathe in, breathe out, not a problem. So actually, radiology have been very accommodating. I haven't met a radiologist yet who's even been bothered by doing this. Says, yeah, it's fine. And the radiation dose, we're recommending ultra-low dose, which is about 30 chest X-rays, or about, I understand it's about the same as living in Wales for 3 months in the Granite Mountains. So it's not a high radiation dose at all. So that is a really important thing. And now today, if you see a patient with pectus, I recommend you maybe write on the CT request, please could you do it on end inspiration and end expiration? And I guarantee you'll see 30% differences. This is a bit of a scary slide for you. It's like, oh, God, what the hell is he talking about? I went and got a bit geeky about what else can you measure on the CT. And actually, there's a giant literature, and there's a few people in the world that are proper obsessed with this. And the more you measure stuff, the more you realize that Haller really sucks off its face. You know, we're using a sideways measurement to measure how dipped the middle is. And that's totally bonkers. So half of the score of Haller is how wide you are. And that's just dumb. So the better measure is actually correction index, as in how dipped you are. You know, the people that see a lot of pectus here will all be able to say, yeah, I've seen some Haller indexes that are 3.3, but they're miles away. And I've seen some really bad-looking ones where the Haller doesn't reflect it. So correction index is a lot better. There are actually a few other ones as well. You can measure the proportion of the dip to the vertebral body. There's a thing called Titanic index, is how high up does the pectus start to dip, and then everybody's got asymmetry, so I think it's worth measuring these things. So we're going to try and collect all this. So again, we're going to have the world's biggest database of CT scans pre and post-op in this area, so we can really find out what is the criteria that we should be using to recommend surgery, which I think will be another fantastic thing about this trial. CPET. The more you dip into CPET, the more complicated it gets. And I think for this audience, I think basically just understand that we're going to be doing lots of post-op ones that have never been done before. Even Dawn Jarolewski doesn't do lots and lots of CPETs post-op. We're doing 1 year and 3 years. And in the delayed group, they get it 1 year later, we're going to do it straight into randomization and then 1 year afterwards when you haven't had anything. Just to prove to NHS England that you don't suddenly magically get better. Because obviously they would, wouldn't they? Well, they're not going to. But we've actually unified the protocol. We've discovered that some people use different ramping of how difficult it gets. Some people use all sorts of different things. A lot of people use different protocols for how they measure percentage predicted, all those sort of things. So we've unified all that. And actually, I've been hugely impressed with the UK's CPET physicians. They've come together brilliantly. They've agreed. We've got a whole manual on how to do the CPET, and hats off to them. They've been wonderful in our support, and Chris Satt has been brilliantly helping us as well. And many other people here in this room have helped us with this, which is great. This is the complicated what happens in the study, but basically we're hopefully going to open centres in July. We've just submitted it in for ethics, so it'll hopefully come back in about 8 to 12 weeks, and then local units can start opening and applying. We're going to hopefully do a 2-year recruitment phase, and then do the surgery up to about 3 years, and then we'll follow them up. Not everyone's going to get a CPEX at 3 years after their operation. If you imagine there's a 2-year randomization phase, so in 2 years in you're randomized to delayed surgery, that's year 3. You're going to have your bar out at year 6, aren't you? So actually not everyone's going to get that 3-year CPET, but these are things that we just had to decide because you have to get the cost under 2 million quid. So we had to make some compromises, but we're all going to get the primary outcome measure at 1 year, which is great. There's the nasty evil pilot. If you don't achieve it, you lose all your money. So please do open your centres, otherwise my ass is grass. So we have to achieve all these. I don't have any worries about the patients. I do have worries about can we get patients into theatre with lung cancer screening and the busyness of units and things. So we're going to set up a national waiting list. So there might be some patients in Middlesbrough that I don't have a slot for. I'll put it on a national waiting list. When someone's consented, they'll be asked what units would you be happy to have your operation for. So maybe if I